insurance is a big deal, and we look at this and we know this is how your staff reacts when you come back from another CE course, right? Oh, well, my gosh, what are we going to do now? Dr. Drake just came back from another course. Uh, and the insurance is a big part of this because your staff, for the most part, is busy. And if you come back and you tell your office manager, well, by gosh, we're going to start making sleep devices now, and you've got to handle that too, right? That's how she's going to feel when you look at this. And uh, there are a lot of moving parts, as you like to say, Guy, and you got to make sure that all of these dots connect as you do this, because insurance can be a real burden on your entire practice. And most of you, that's why you're on here tonight. So we want to talk about that, and talk about the different ways that we can get this thing going.
Well, good luck to you, but we're going to help you. And the good news is you're in the right place at the right time. We've been doing this for over a dozen years each, I think. So I think it's close to 2 dozen if you add them together. And I can tell you beyond a shadow of a doubt that right now is the best time to get involved in dental sleep there's ever been, because it's much easier to get paid than it used to be. When Rich and I started, they didn't pay, and we're talking about medical insurance. We're gonna go into more detail in a moment, but you really do get paid now, and it can be very profitable to the point where Rich and myself, that's where the vast majority of our income comes from. We don't have dental practices anymore, so it's the right place at the right time, and now it's very exciting. So it is a little bit of a hassle, but we're going to try to clear up a few items on it for you. It's changing every day, and I put this slide in there because it's ongoing. If we talk about this a year from now, there's going to be something a little bit different, and the way they pay is different, how we get paid, the codes, a lot of things are changing. But the good news is, again, it's changing for the positive for the dentist. It's easier to get paid. It's paying well, and just understand it's a process, and getting a medical insurance billing under your belt in your practice takes a little bit of time, and it takes some patience, but it's well worth it, like anything else in life. And stick with us. And we've talked about this in a lot of the webinars that we have, and we feel that there's, if you just get your systems in place and you look at the pillars for dental sleep, and we call them the pillars. If you were building a table, these are the things you need to have the systems in your office. And we got to do screening, testing. We already talked about our practice management system, that we have really the best one out there for that. But then we put insurance billing right up here, because you know what, if you don't get paid, you're not going to want to do this. No matter how much you love helping your patients and enjoy doing dental sleep, getting paid is a big part of it. And again, if you hit the next slide, this can be you. If you just get a few systems in place. And I'm telling you, having had a restorative practice for over 20 years, and doing all the challenges there, and a big restorative practice, big being, we did big cases, and it's a lot of hassles. And dental sleep can be so much more rewarding even than general dentistry, or at least equally rewarding to add to your existing practice. So don't let insurance stop you from doing this. As a matter of fact, I will turn that around and saying insurance should help you be able to do this, because your patients will be able to afford to do this. They'll thank you for handling insurance, and you're going to get a lot of gratitude.
So who should be doing this, guys? Should we be doing this ourselves, or should we hire somebody else to do it? So I think the quick answer is, use somebody else to do it. It's certainly to get started with. There are a lot of third-party billers out there, and we're happy to, if you guys give us a call or send us an email, we're happy to talk about that. With you personally. But again, this can be a burden if you don't have your systems in place, and you're not getting everything lined up and making sure that you do everything right. So the quick answer is use a third-party biller, but we're going to talk about the process for how you do this and what you do. And I know, Guy, you were a part of writing this logic.
I wrote that, and if you zoom in, that is some of the logic built into our software to help our insurance billers make decisions on every given patient. So if you've ever written a software program or an algorithm, that's a true algorithm. And so the reason I have it here is for you to understand it's a complex problem. And we're not saying dump this off on the third-party billers forever necessarily, but if you're new in particular, that's a great way to start, because there are people that do this, just dental sleep billing, and again, that wasn't around when we started this. So you can get some help, and when you feel comfortable to do it yourself, then do it yourself. We're going to give you the
Right.
basics for it here right now, so that you can do it for yourself if you want. But getting help is always a good idea.
And remember, we're crossing a line here. We draw this in the sand, so to speak, metaphorically, but you are crossing a line from doing dentistry into practicing medicine. Now, we say, well, you can't practice medicine as a dentist, but yet this is one of the only area that I know of where you have a tool at your disposal. We showed the picture of that clear dream from Keller, where you can actually treat a medical disease with a dental device. So I think you got to get that out right off the bat. So, we're dealing with medical insurance. We're not dealing with dental insurance. And you just need to make sure that your patients understand that, make sure that you and your staff do. So, even if you're just getting started in this, or you've been a pro at it for a long time, there's some things I think you can learn here. So what's different, Guy, just the last couple of years, what do you think has changed in your mind about just how you used to view this as a dentist and how you do now? You're still a dentist, but how you view this differently.
And it's taken me a while to understand this. We have been told as dentists, if we aren't going to get paid our full fee, then we need to declare this to our insurance companies. That's what we mean by third parties. And, it's unethical if you don't tell them that you're not getting paid or you didn't collect all the money. In medicine, it's more the norm for this to write off certain cases, and if patients can't afford to pay, you're supposed to forgive them. And the reason being, I guess, if you think about it logically, this is just my opinion on it, but medicine's life and death, and dentistry oftentimes is not. And should we hold back care due to payment for something that could literally alter someone's life? And I think that's one of the difference. But this is the ADA Code of Ethics. A dentist who accepts a third-party payment, so in other words, an insurance payment, under a co-payment plan as a payment in full without disclosing it to the third parties that the patient's payment portion will not be collected, is engaged in overbilling. So basically, if you don't collect the patient's portion from a patient, and if you don't turn around and tell the insurance that you didn't do that, then the ADA says that's unethical. And then if you contrast
But
that,
what does the medical side of things say?
right,
We
and
were surprised when we found this, weren't we?
yeah, you can read it, Rich, and tell me what you think about the difference.
Well, again, I don't know why these things are what they are, but I think, I went in, got my blood drawn the other day, and I said, well, how much is this going to cost me? And they're like, I don't know, I don't know. They said, just pay it or don't pay it. We don't care. It's almost like the medical side of things is just doing things for insurance, and that's about it. So I don't know where this got started or what we're doing, but that's right out of the American Medical Association Code of Ethics. They're made conscious of the cost of healthcare through co-payments, right? And when co-payment's a barrier to needed care because of financial hardship, we should forgive it or waive it. And that's in complete contrast to what the ADA puts out. So I think this is a real shift that we as dentists have to get over. And we are dealing with a life or death situation when we're talking about sleep apnea. So I think that we need to consider ways to be a little bit more flexible. Everything we do, everything we teach is above the bar. But you've got to deal with insurance. If you don't deal with insurance, then you're just not going to make as many devices. And Guy, I mean, we do this. We make a bunch of devices. We made thousands and thousands of devices, and done 10,000 consultations. And they sit down and they all ask the same two questions every
Yeah,
time, don't they?
yeah, they want to know how much it's going to cost, and they also want to know that their insurance is kicking something in. And I found this out in my dental practice because I had a Island Dental Spa was my dental practice. So we had a lot of big cases, fee for service, and the same patients that would pay me well over in the tens of thousands of dollars for a case, when it came to this, and they said, well, I don't want to wear a CPAP, I want to wear this. And you would say, good, and here's how much it is. And then back then, medical insurances wouldn't pay for it, or we didn't know how to get coverage like we do now. And they'd say, well, no, it doesn't cover it. And the same patient would argue and feel like that it was wrong that their medical insurance wasn't paying for this medical procedure. So that they want to know that you're doing that your office has this under control, and that you've done enough research and effort to get the medical insurance handled, even if it's only puts in a portion.
Well, why do you think, Guy, you could sit there and you could sell these $10,000, $20,000 cases with these people, and they pay for it, but you turn around and now you're charging not anywhere near that to do your dental therapy? Why can't you sell them that? Do you think it just has something to do with they're paying more for their medical insurance, and they want to make sure that they're
Yeah.
getting something?
Took your car somewhere to get repaired. You got an fender bender, and the best mechanic on earth. And he says, or not mechanic, but the body man, and he says, no, we don't take.
Okay, I think I'm losing Guy there. So I get your point, though, Guy. We don't take your insurance. You're probably going to go somewhere else. You're right. So we're paying for that insurance, and we're doing it. The other thing I want to put on here too, until we get Guy back, is MD referrals. You think about this and you think, my goodness, what in the world does that have to do with it? And for the most part, it has a lot to do with it, because our physician colleagues have to deal with insurance, and they have to deal with these types of things. And I think they begrudge us as dentists, not just a little bit, but a lot, that we have been immune to a lot of that. Now, it is getting worse, and there are some things happening out there, in ways. But if you don't deal with insurance, you get a referral from an MD, and that patient comes in and you say, hey, it's $10,000 for a dental device. We don't take your insurance. You just pay me. That's it. There's no other options. When that patient goes back and tells that physician that, I guarantee you that you are not going to get any more referrals from that guy. So be careful as you choose this and what you do. So
Can you
I
hear me
kind of
now?
feel that for you there, Guy. Yeah. So
Yeah. Good deal.
I finished your story about the
Thank you.
the insurance thing. So you think about developing a fee. This is kind of your slide here, Guy. Talk about this for just a
Yeah,
second.
and sorry I lost the internet there, but basically what you want to do is figure out what you need for each device on average to make you happy to do this. If you're not going to make as much as you make doing crowns or root canals or whatever you like to do in your practice, you just won't do it. And we don't need to spend a lot of time on this. If you basically you take that procedure that you do and find out how much you're charging for chair time or doctor time or both, and subtract the lab bill out. And just go to the next slide so that we can kind of get to this. An example of that would be if you're doing a crown, and the numbers mean nothing here, but just say you were charging $1,300 for a crown, and your lab fee was $300. Well, that's $1,000 that you're making after the lab fee. And if it took you 2 hours of chair time, then that's $500 an hour for your chair time and that you're charging. If it took an hour of doctor time, then that's $1,000 an hour of doctor time. So, you can use this kind of formula and play with it, figure out the procedures that you like to do in your office, and then kind of reverse it. And we have some numbers here for you that if you're efficient, now, if you're not using some of the systems we use, you're going to have to increase this chair time and doctor time. I spend less than an hour with my patients per case because we're very efficient. So we put an hour because we feel that's what you can do it in. 2.5 hours of chair time if you're fairly efficient at it and you've got decent systems. If you're really new to this, you may add a little bit of that, but you can just basically reverse the formula. And I suggest that you maybe average the chair time and doctor time, because you're going to have a little bit less doctor time in these procedures than you would for something like a crown. And you can see in this particular case, you take that doctor time, it's 1,000, and you add whatever we think for a case. We put 350. Again, you can get the clear dream for 299, and in this scenario, that's what you would need. And so we're not here to say these numbers are the right numbers, but you need to figure out at what dollar amount would I just as soon do this as I would anything else in my practice. And then that's what you need to get, or you won't do it, because you need to profit.
Yeah,
And you may get more on some cases, less on others, depending on your billing system, but that's the number that you need to at least average.
yeah, and we're going to talk about that a little bit. The only thing I'd add to that, Guy, would be it's going to take you a little bit longer and a little bit more than you think it will. at least initially. So until you get about 100 devices under your belt,
Right.
you're going to have to make some decisions about this. So let's get into the nuts and bolts and nitty gritty of this stuff now. We're going to talk about Medicare. Medicare is a beast unto itself, so we're going to kind of separate it out to talk about that. And we're going to talk about in and out of network, with medical payers. So some of you may be in network with a particular dental plan. But that doesn't mean that you are in network with that particular company's medical plan. So we ask this, we get in front of what, Guy, at least 1,000 dentists in our 2-day courses every single year. And we have less than 1% of the dentists that we see in person who are actually in network in a medical plan. So, but we're going to talk about that and we'll see. And that's your favorite thing, right, Guy? We're going to talk about that too, right? The billing systems.
Yeah, you've got to have a system, and we'll kind of give you 2 or 3 options on this. And I think that's where people drop the balls. They don't have a system and stick with it. So we'll get to all these. And again, is it medical or is it dental? Anytime we're talking about making mandibular advancement devices for airway problems, it's a medical insurance. And what does insurance cover? Does it cover snoring? Does it cover upper airway resistance syndrome? Does it cover OSA? Well, the answer is, as far as I know, the only one that's a safe bet is that last one is OSA. They have to have a diagnosis of obstructive sleep apnea to get coverage of medical insurance. Any of these other things above there, people very well may benefit from a treatment with a mandibular advancement device. Don't let it don't be confused and think that those people, just because they don't have a diagnosis of apnea, it
Doesn't
doesn't
mean that they
preclude it.
don't need treatment, right?
Absolutely. But if you're going to get paid by medical insurances, it has to have an OSA diagnosis the vast majority of the time. There's a new code, 78.53. It's not as widely accepted, so we recommend using the diagnosis code of 327.23. That's what you have to put on the form when you submit this. In medicine, all billed procedures have to have, for the most part, a associated diagnosis code with it, which is a little different than dentistry. You don't have to have a caries code when you bill a 2-surface composite. In medicine, you do. So understand that's the first thing, that you've got to make sure the patient has a diagnosis, or they're not going to get any medical insurance coverage.
Yeah, and again, you can market to snoring patients, and most people don't even know what upper airway resistance syndrome is. But again, if you've got a very sleepy, very tired patient like that, sometimes you can write letters and you can get things covered. But as a general rule, they have to be diagnosed with sleep apnea. That is done through some type of sleep test, either a home sleep test or a PSG. That is done by a physician, not you. So let's just make sure that that's clear. So that's not something that you provide, but that's something that the physician supplies through a sleep test. So when we think about what we need to get paid with this, okay, because this is how we started, right, Guy? We just picked up the phone and we called the insurance company and we said, "My gosh, this guy's got sleep apnea. I want to make him a dental device. What do you need to get paid?" And this is kind of that big thing, right? I mean, if you had all of this every single time, it would increase your odds of getting paid significantly, right? But do you need all of this every time?
No, I mean, the only one you absolutely have to have is a sleep test and a diagnosis. You're not going to get paid unless you have that one. But as you go down the list, sometimes you do need one or more or all of these items. And so the list is there on your screen for a moment. Just understand that all insurance companies don't operate the same way. The same insurance company may ask for different documentation on different patients, even though it's the same insurance company. So these are the things that you may need to be prepared to supply them with. And I don't know if we need to go through those, but
No, I don't think so. I think this is just what in my office, this is kind of what we use as a cheat sheet.
right.
What do you need to get paid for this? And we expect this to be yes. And when they say they don't need it, we gladly just cross a line through it, because that's one less thing we have to get, right? So let's jump into it. Let's talk about Medicare, okay? It is a maze out there, right? I mean, you think about Medicare, they came out with this global fee, E0486, through these local coverage determinations a few years back. And it's actually a good thing, because the other payers are starting to follow suit. And up until they came out with that code, we really didn't have anything to file. We were using all kinds of weird codes and different things that really wasn't descriptive for what we do, okay? But now Medicare does pay for this, and they have an allowable part. So there's 4 different jurisdictions, and we'll kind of go through these rules as we go about it. So, but you've got to pick one way of doing this. You can opt out and just not deal with it. We'll talk about that, opt in, and then you can participate or non-participate, kind of on a limited type of basis in how you do that. So. This is an important slide for Medicare. I want you guys to really get your arms around this, because this pretty much summarizes what you can do as a dentist and what you can charge for and how you can do it. So we're gonna go through parts of these in the next several slides, but I want all of you to understand that as a physician out there, if you were a cardiologist, you would have to opt in to Medicare, because 80% of your patients are Medicare patients. So you would fill out this CMS 460 form, and that means you are all in with Medicare. That means you accept their fee. You cannot balance bill the patient any difference, right? Any of that stuff. So Part B are the office visits, those types of things, and that has an associated application that you fill out. The dental devices that we deal with is through DME. That stands for Durable Medical Equipment, and that is dealt with through the 855S form, okay? So again, let's kind of, as we walk through this, I do want you guys to kind of have this overview that you opt out or you opt in, okay? You opt in, and we'll talk about opting out first, and then there's this kind of in between where you participate or non-participate on a limited basis. So what does it mean to opt out, Guy?
Well, opt out means you basically say, I'm not going to deal with Medicare. You're just going to, your patients are going to pay you whatever your fee is. It also means the patient can't approach Medicare and say, I went to a dentist, had this procedure done, and I'd like to be reimbursed for this. So it's basically, I'm not doing anything with Medicare. Understand, if you opt out, you can't opt back in for 2 years, and opting out isn't simple either. You've got to fill out paperwork to opt out as well. So it's not like you just opt out by default. So it doesn't get you out of doing something as well. And just to get to it, we really don't recommend opting out for the most part, because you're leaving money on the table, and that amount of money can be anywhere from $1,000. One of the questions someone typed in mine and Rich's area, it's the LCD is a local coverage determinant, and that's I think I said that right, and it's really what that region what they cover. And it can be what's the higher regions, Rich? Maybe $1,500 or so. So if you opt out, your patient doesn't have access to that money. So we don't recommend you do it. But if you're going to do it, you need to make sure when the patient comes in that they fill out this next slide picture of, which I think is the advanced beneficiary notice. And this is basically a form that says, I'm coming to a non-Medicare provider, and they fill that out, and you get a copy of that signed, so that the patient is aware that they are relinquishing their Medicare rights by coming to your office.
Yeah, that makes sense, right? I mean, as a patient, we want these little old people, which won't be long, and I'll be a Medicare patient myself, right? But we want them to be protected. If they're going to go see a doctor, and we just want some of the transparency out there for whether or not they're going to get it covered. So again, the opposite extreme of that, like Guy said, it's a 2-year contract. It's a simple couple of pages. You do it, and it's going to last for 2 years. So be careful before you do that. If you want to do it, then just know it's going to last 2 years. And the opposite extreme of that is where you opt in with the Form 460, and that basically lasts until you don't file a claim for a year, and then it becomes inoperative. But we still use these advanced beneficiary notices in dealing with Medicare patients. And then there's this kind of in between, right, where you become a provider and for the DME and the Part B, but you have the ability to balance bill patients as a difference. So And that's all done through this check assignments, this accept assignments of benefits, which is a box 27 on a CMS 1500 claim form. So again, this can get a little confusing, and we certainly don't want it to be. So we've talked about opting out, we've talked about opting in, and then we talk about if we're going to participate or non-participate on a limited basis. Then for the DME, this is where we get this through the 855S form. And then on the CMS 1500 claim form, if box 27 is, do we accept assignment of benefits or not? And if we check yes to that, then as you see here, Medicare rewards you for doing that, and they allow 5% more than they do if you check no on that particular box. But the big caveat here is you can't balance bill the patient the difference between your fee and what Medicare allows. And I know in my jurisdiction here in Texas that Medicare only allows about $1,200 for this, for the dental devices. So if I want to charge a patient $2,000, I can't bill them for more than what Medicare allows.
Right. That's one of the questions that keeps coming in. It depends on what region you're in, and if you want to know specifics amount, then feel free to contact our office, and we can find out what region you're in and what your local your LCD coverage is. In my region, it's a little over $1,000. So I don't want to accept this on a regular basis, because when I did that, the process where we've determined how much we need to be happy to do this, $1,000 is a little less that makes me happy to do this with our overhead and so forth. So for the most part, because I became a non-participating provider, we can switch, and we don't check that assignment of benefits box. And if you're doing it with DS3, there's you just put that in the patient information, and automatically the checks go to the patient now. And so the Medicare check goes to the patient. If the patient has supplemental insurance, that check goes to the patient, and you can charge the patient whatever your normal fee is for this, and you can balance bill the patient. So for the most part, that's what we do. And again, why would you not at least do this? Because your patient's going to get some money coming back to them. So remember, you do have to have a way to file this, and a lot of the dental softwares don't do it. And I'll remind people, if you want a free trial of our software, just type in free trial, and you can see how easy that is done through our software. But if there's a case, let me kind of give another scenario, Rich. I've got a patient that's referred by one of my good referring physicians, or a new one I'm trying to really get to refer more. The patient can't wear CPAP, they're allergic to latex or whatever. They just can't deal with the CPAP. They have severe apnea, just had bypass surgery, and I feel like, man, this patient really needs this, and I want to help the referral source out. And the patient just says, I can't afford it. I can't afford to pay anything. I'm on a fixed income, and I can't. Then I can check the accept assignment of benefits box. I'll have the checks come to me, and for that patient, I make whatever my local area is, and I'm happy to do that. And I do that several times a month for those reasons.
Yeah, that's good. Maybe that's why you get so many referrals from some of these guys, and that's why those little old ladies bring you all those cookies and all those nice things, right?
Yes. Yes, and remember, it is the E0486. That's what someone's asking here as well. E0486 is the code that we bill. It's a global fee. It's a DME code. Durable Medical Equipment is what DME stands for. And that's for all the devices and your appointments for 90 days. Unless you're a Part B provider, and then after the 90 days you can bill for your medical office visits, which is a whole nother thing. You've got to be really well prepared and make sure you have very adequate chart notes.
And chart notes, and Medicare is very specific. If you want to bill for a specific code, then you have to touch the patient in X number of places and review X number of symptoms and do all that kind of stuff. So for the most part, in my office, even after doing this for 14 years now, we bill for E0486, and E0486 is the custom device code. There are Medicare devices that they require that you use, right? Basically, those are the TAP and the Herbst and the SUAD, and right? or some form of those in some way or another.
Those are the two main that we use, and a custom means that it's one of those approved ones, and they're made specifically for that patient. They're not a bowl and bite device. So we take impressions, send it to the lab, and they're custom made, like a partial or a crown or something like that. It's made for that specific patient.
So this is kind of what Medicare says about this particular E0486. So that's kind of small. Let's break this down, okay? So patients have to see the MD, and they have to have a face-to-face with their MD about this, okay? For the disease process itself, for mild, moderate, and severe, they have to have a minimum number of events and comorbidities, right? And you see even here with severe, they have to be PAP intolerant in order to use our dental device. So it requires a prescription by the MD, and it's performed and billed by the dentist. Okay. Now we are seeing more and more physicians doing some of this around the country. Actually, we don't think that's a good idea because I don't think they can meet the standard of care that's required to manage some of the things that happen. But that's kind of it in a nutshell. So E0486, it's a global fee as we do this. You can opt in, you can opt out, right? The application that you need for the DME is the 855S, as in Sam. I think the best way to do this is through the PACOS online system, and we'll leave that up there for just a minute.
And if you miss it somehow, just info@dentalsleepsolutions.com, and our team will be happy to give you this or any other information, because I know we're going fairly quick because we only have an hour for the webinar. So if you didn't get something written down, feel free to contact us, and we will get you that information, including this website if you don't have time to write it down.
And why do you have third-party billers up there, Guy?
Pardon me?
Why do we have third-party billers up there?
I don't know why that says that there.
Well, just, don't take on all of this yourself, from the beginning. Maybe get somebody else to help you, get a third-party biller involved. Again, we're happy to get some of this stuff in there.
Yeah, I guess what that's for is some of the third-party. And by the way, we can recommend third-party billers as well, and we have people we work with, and we don't get anything out of those referrals. We just want to see dentists do this, and they will help you with this Medicare application for a fee which is small when you consider the amount of work it goes into it.
So again, we understand we are flying through this stuff to get through this, but I don't think anybody has as good a handle on this as we do out there. And I think the important thing is the more you learn about this, the more powerful it is. And you guys, you dentists out there, you office managers, you hygienists, whoever's out there listening, you need to get a game plan. This doesn't just happen on its own, right? You have got to talk about this. How do we want to handle these Medicare patients? Maybe you live in a place where there isn't anybody that's 65 years old or older. A guy lives in Florida. He can't afford to not deal with Medicare, right? Because half the year, most of your population is Medicare. So again, assign the application to a staff member, right? This is your responsibility. Do this. Because otherwise it won't get done. And we know from experience in doing this. And then bill appropriately. Choose the right boxes, understand what you can bill for, what those allowables are. And again, we can help you. So that's your absolute crash course on Medicare and how you deal with that. E0486, we did have a question come through, Guy. That is a universal insurance code that we use with all insurance companies, not just Medicare. But now we're going to talk about the other payers out there: Blue Cross Blue Shield, Anthem, United Healthcare, Humana, right? Aetna, you just go through this whole list, and that's kind of your thing, guys. So talk to us about that.
Well, and there's a question up right now: Can you get in network? And the answer to that is it depends. Most of the time, yes. Some medical insurances will not let dentists in network. Sometimes they only let oral surgeons in network, but for the most part, the medical insurance companies will let dentists in network, and then you've just got to decide what you want to do. If you want to be in network, it makes everything much more simple after you've gone through the process. There's a process of deciding the fee. There's a process of reading the big paperwork they give you. And I know Rich is in network with a couple of medical insurance companies. I am personally not currently, although I'm considering it. And there's a lot of work up front, but once the work up front is completed, you know how much they're going to pay you for each device you do. And you can sit down with your patients and know exactly here's what your copay is because you've agreed to it ahead of time. You are also under a little bit more of an obligation to collect co-payments and so forth because likely the paperwork that you signed said something about that was your responsibility. Now you have a legal contract with them.
Right.
If you don't become in network, it's a little different than Medicare. By default, you are out of network. So unlike Medicare, where you have to do something to opt out, if you've done nothing with the medical insurance companies, then you are out of network by default. So it doesn't require paperwork. And I guess the advantages to out of network are sometimes the allowable amounts are, I don't know what you did there, Rich, but we see the whole, you got off presentation somehow. You want to and out of network, sometimes the allowable amounts are considerably more. You just want to hit your view, your slide, start the slideshow again. That's what happened. There you go. The allowable amounts sometimes are considerably more than in network. You're not under as much legal contracts with these insurance companies to collect co-payments and so forth. So, I mean, there might be some state laws that govern that, but for the most part, you don't have a contract with them. And if you don't have a provider in your area, this gap coverage is basically a way that you can become in network on per cases, and you can negotiate those fees per case. So the reason I'm considering going in network is because there hasn't been anybody with one of the medical insurance companies in my area for years, and now there is. And we used to be able to get gap coverage, which sometimes the benefits were greater for the patient. So we would basically become in network for that one patient. Now I can't do that, so I have to stay out of network, and we're looking to see whether I'm still doing better case acceptance and reimbursement wise based on that, the way I'm currently doing versus if I became a network and accepted the amount that they may allow.
Okay, and you have here, Guy, too, possibly higher reimbursement amounts, right? We don't really know, and that's part of the challenge in this is, you know, with my Aetna patients, for example, they come in, we negotiated a fee 10 years ago with Aetna, and that's the fee I have. They've met all of their deductible. They pay 80%. I know exactly what the patient's portion is going to be.
Right.
That makes it easier to sell that case for that patient because we know. Now, when you're out of network, you don't know because until you have a history with a particular insurance company, you don't know what they'll allow.
Right.
No, I mean, think about it. If you and I own the insurance company, Guy, and you owned it, and I called you up and said, "Hey, what do you cover 2,000?" And you go, "Yeah," and I go, "Oh, I meant 3,000." Do you cover 3,000?
Yeah.
How about 4? I mean, so that makes sense that they're not going to tell us what that is. And again, the gap part comes in because in a PPO, as a insurance constituent, if no one in network provides this service, then there is a gap in that coverage. So what that does is when you apply for that gap coverage and are granted it, it allows the patient to get in-network benefits even though they're going out of network, and they usually allow more for that. So that's kind of where that is. So we've gone through. How are we doing on time, Guy?
I think we're doing all right. We're getting there. I think we're little. Yeah, we're just gonna keep going, but we should be all right. So if you're out of network, you really, well, backing up for a second, what Rich said, because if you're in network, the system's pretty straightforward. You know what their portion is. You can have those checks go to you or them, and it's just, you don't really have to have a system because you've predetermined it by all that work up front. If you're out of network, because you don't know how much they're going to allow, it becomes confusing. And I think this is key to being successful, is at least picking a system and sticking with it. For years, I was a fee for service. So I told my patients, look, I'm going to file this. I don't know what they allow. You may get a penny back. You may get it all reimbursed. You're going to pay me my fee, and the check's going to go to you. That's exactly how I did it for my restorative patients, and that works, and that's a pretty simple system. But you know what? If you look, I think we may have some figures at the bottom. Less than half my patients said yes to treatment back then. Once I started accepting assignment of benefits and getting some of this money sent to me, and then the patient paying a portion, then my success rates went up. So you can have patients, the checks come to you from the insurance company, and then you can have the patient pay their portion. The problem is you don't know exactly what that portion might be. So are you willing to accept different amounts for different patients? Are you willing to accept what the insurance companies allows, which is something that I typically do. Whatever the insurance companies allow, we just accept that. And then there's a risk involved there, but at least that way the patients and the feel like, well, we're dedicated to getting this done for them. So if you're going to accept assignment of benefits, and you don't have an in-service, I mean, a contract with them, in network rather, you really want to, at least before you see your patients, find out, make sure it's covered, that the E0486 is covered, and find out how much of their deductible's been met, and how much it is, and how much has been met, and how much they're going to pay afterwards. They'll tell you the percentage that they're going to pay, but you're not going to know that number to put in there. Do they allow $1,000? They allow $5,000? They allow somewhere in between? Probably is the answer, but we don't know that. But the key there also is to ask, is a pre-authorization required? And this isn't as common in dentistry. In medicine, pre-authorization means that even if it's an allowed service, you have to have it pre-authorized, which oftentimes means the primary care has to initiate this by saying, yes, we want our patient to have this, and we want to pre-authorize this. Now, sometimes you can call them yourself and just get this done over the phone or with some paperwork. But if you don't pre-authorize a dental device for the E0486 and it was required, and now you bill them later, do you have any luck with getting paid for those patients ever? I mean, you're just not going to get paid. It's you've missed that little hurdle. So understanding the difference between verification of benefits and pre-authorization is important.
And assume, I think, as a general rule that our dental devices always need to be pre-authorized, because it's a severe penalty if you start that device on that patient without getting that authorization. Then there is no recourse for either you or the patient to do that.
Right. And back to the previous slide to answer a question while we're on the subject is we have up there that you might want to use if you're testing your patients before or after treatment, the sleep testing. If you're doing out-of-network billing, then we want to take the money out of the same pot. So a company who bills out-of-network might be beneficial to the patient, not necessarily to us, but to the patient, because we're reducing the same deductible. If we're doing in-network billing, then when we follow up with sleep testing for titration, then that patient's deductible may have already been met by your device. So that's the answer to the reason why we have that on there. Man, I just pulled this off the internet, that little picture up in the right-hand corner, because it changes every day, and I don't even know if that's the proper book today, but there's a handful of codes you can use instead of the E0486 for follow-up visits and so forth, but that's another layer of complexity, right, Rich?
It absolutely is, and as you get started in this, again, I've been doing this 14 years and made 5,000 dental devices. The only code we use is E0486. That's the only one I use in my office. Do we leave some money on the table? Yeah, maybe a little bit. But it's so simple in our office, in our systems, and what we do. So, if you're going to use other codes and do that, then just read the description of the code and make sure that you are doing what it says you're supposed to be doing. And above and beyond that, make sure that you're documenting it, because if you don't document it, it didn't happen. So, as you do that, be careful. Are you using an EMR, something that's an electronic medical record, as you consider doing this? We have heard about more and more dentists getting audited, especially those who do a lot of dental sleep. So I don't think certainly wouldn't let that scare you away from doing it, but I would be careful about.
We occasionally bill for the exam and so forth, but you got to have it documented well. And like you said, that's your main thing comes from E0486. And if you're just getting started, just bill the 0486 and put all your, just like you do with your Medicare patients, and make it a global fee. It makes life easy. It makes it less likely that you're going to have any problems with audits and things like that. And then as you get your systems in place, and certainly billing for these other codes, when appropriate, you should, but you've got to have the proper documentation. So here it is. We've got it back on the screen. You know, we went through Medicare. I think we've, you know, threw a lot of information at you here, but that's one thing. If you're going to be doing dental devices, you've got to make a decision on that, on Medicare, and then getting a billing system and deciding whether they're going to be in or out of network. And understand you can be in network with some medical insurance companies and out with others, but having a plan and a system. I think that's what we do better than anybody, Rich, is we help dentists have systems in place that make this work. If you have a system, this is easy, and have a plan. It's when we're kind of all over the board, and I think the third-party billers can really help you with this as well, and that's why we keep mentioning that.
Well, it kind of goes without saying, doesn't it? That the less you can get a patient to pay, the more acceptance you're going to get, right?
Yeah, and I think if you go down to the next slide, because I think we want to have some time for questions. This, you know, the less they pay, the more you'll do, and I don't care how good you are. And I think that's what Rich just said. But to reemphasize that, I think the next slide. I think this is from my office from years and years, and you can just look at it. You know, when I asked for the patients, like my restorative patients, about 1 out of 3 said yes. When I started getting a portion from the insurance to me, and the patient paying a portion, we got closer to 50%. And we try to keep it for patients who can't afford it in particular. Most people can afford 500. I think if they pay a little something, they're going to value it more. And if we have to, we'll reduce what we charge and what they pay out of their pocket, because again, we're providing a life-saving procedure, and we get the checks coming to us, and we have a good system now. And you know, pushing 3 out of 4 patients that I see from my medical referrals say yes to treatment.
That's pretty good, man. That's pretty good. We get in front of a lot of dentists all over the country, and again, a lot of this are the systems. You know, I mean, if you think about, I know, Guy, I've been to your office, and you've taught me a lot about this. But when, you know, patients come in and they sit down for a consultation, we have already done much of this. We have already called their insurance company. We have gotten a verification of benefits, the VOB. We know what their deductible is. We know what they're going to pay. You know, we have an idea because we kept a spreadsheet of all the companies that we're out of network with, what they're going to do. So we have a very good idea about what the insurance is going to pay. And again, you see this with what Guy has done. So it's great to get paid for saving lives, isn't it?
It is. It is very rewarding. You should not let billing or medical insurance billing in particular be the hurdle that keeps you from getting involved in this. As a matter of fact, it should be maybe a motivator to do this, because now there's money to be paid by people other than your patients to provide this life-saving treatment, and it's readily paid if you have the right system. And again, if you want to trial our system, just type in free trial, and we can help you with that.